If anyone's on camera wants to give me a thumbs up if you can hear me, go ahead. On behalf of New England's MHTTC's Early Psychosis Learning Collaborative, I am very excited to welcome all of you to the 6th of our series of online discussions on implementing real-world evidence-based services for early psychosis and clinical high risk for psychosis. Today's discussion is called Health Plan Advocacy 101, What Steps Can Be Taken for Bundled Payment for Coordinated Specialty Care Across Plans, with Dr. Ken Duckworth, who will be speaking from his unique experience as both the Chief Medical Officer for the National Alliance on Mental Illness and the Medical Director for Behavioral Health at Blue Cross Blue Shield of Massachusetts. I hope you'll all take a moment to introduce yourselves in the chat box. Let us know where you're tuning in from. And also, please feel free to use that chat box to share any comments, questions that come up for you throughout the talk. My name is Michelle Friedman-Yakubian. I'm a clinical psychologist and early psychosis trainer for the New England Mental Health Technology Transfer Center. I'm also the clinical director of CEDAR, which is a coordinated specialty care clinic for youth at clinical high risk for psychosis in Boston. Over the last 5 months, I guess has been a virtual clinic in which I operate out of this room in my home in Cambridge, Massachusetts. The goal of this series is to bring together leaders, clinicians, administrators, and other stakeholders that are interested in working together to increase feasibility and scalability of specialized early psychosis and clinical high risk for psychosis clinic treatment. The format of each discussion includes a 30-minute presentation by an invited expert, followed by 30 minutes of questions and discussion by participants. We really hope that you'll choose to keep your cameras on today and to participate actively in this discussion. Our hope that some of you will use these discussions as a chance to network and develop working groups to try out strategies that are discussed and to advance important initiatives that will make high quality coordinated specialty care accessible to young people and families that need it. So during the discussion part, you can either turn on your camera, speak directly, or you can type questions into the chat, and both are ways to participate. Now, my colleague Rachel will share some housekeeping information to help you get the most out of participating in this discussion.
Next slide, please. Hi, everyone. This is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. I just wanted to review a few housekeeping items with you all before we begin. Participant microphones have been muted on entry, and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat or the raise hand feature during the discussion to have your microphone unmuted. This discussion is being recorded and will be available for viewing at a later time on the MHTTC website as well. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. Our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. Next slide, please. And to ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And with that, it is my pleasure to hand it back over to Dr. Michelle Friedman-Yakubian for introductions.
Thanks. We have a really great presenter today to lead a very timely and important discussion on Healthcare Advocacy 101. What steps can be taken for bundled payment for coordinated specialty care across plans? Dr. Ken Duckworth serves as the Chief Medical Officer for NAMI, the National Alliance on Mental Illness. He is also the Medical Director for Behavioral Health at Blue Cross Blue Shield of Massachusetts. He is double board certified by the American Board of Psychiatry and Neurology in adult and in child and adolescent psychiatry. Ken is an assistant professor at Harvard University Medical School and adjunct clinical assistant professor at Boston University School of Public Health. Ken has served as a board member of the American Association of Community Psychiatrists and has been the deputy commissioner and acting commissioner of the Massachusetts Department of Mental Health. The APA has awarded Ken the Presidential Patient Advocacy Award. He is a distinguished fellow of that organization. Ken grew up with a parent with bipolar disorder, which fuels his passion for system change. So it's my real pleasure to welcome you, Dr. Duckworth, to this discussion. And I want to encourage folks to, turn your cameras on if you'd like. I know it's always nice to be able to see who you're speaking to and to have some bravery. And I'm really looking forward to hearing what you have to say. Thanks very much.
Thanks, Michelle. A couple thoughts. One is I'm speaking on behalf of Ken. So this is not a NAMI position statement, nor is it a Blue Cross Blue Shield of Massachusetts position statement. In essence, I spent my 40s advocating for mental health parity in Congress and in multiple state legislatures. And I took a job at a reasonably progressive health plan from my outdoor perspective, outside the health plan perspective, to join it to figure out how mental health parity could be implemented, only to learn that it has become an incredibly progressive health plan. You can only learn so much from the outside, but I did have a hunch, and it turns out I was right. I also want to say I'm not an expert in paying for coordinated specialty care. I have not written an article or a book on this, but I have now spent 9 solid years inside of a health plan, and I'm going to enumerate some of the many policy improvements that we have seen. And of course, the NAMI job is a love affair of 15 years now for me. This is the job where it's located in the wrong city. And back when there were airplanes and stuff, I took so many shuttles from Boston to Washington. I actually got to know flight attendants by name on a regular basis. That's now, like everything else, completely virtual. So those are just my introductory remarks. Not NAMI, not Blue Cross of Massachusetts, but the reason I tried to put together this very unusual career is I'm interested in the heart, soul, and education of the mental health field. And I'm also incredibly practical. And so, I am into doing. And that's why I took a doing job at Blue Cross. So my friends all thought I was a bad person for leaving clinical practice and going to work for a health plan until I got rid of all the prior authorizations, co-payments, and headaches that befell them. Now, I am sorry to report, they now think I am cool 9 years later. So it took a very long time for people to see that a health plan role is a role that is valuable. So let's just start with 101, American healthcare. We are not France, we are not Sweden. If we were France, Sweden, or Canada, or the National Health Service, a person like me or a person like you would accumulate the leadership job and make the decision to organize payment for a service that was describable, had specific specs, and it would simply happen across the board. America, of course, is a patchwork quilt of health coverage with 40 million people plus or minus unemployed, and without many of them without health insurance. So we're a patchwork, and it's a little bit much more complicated. So had this been taught in France, Sweden, Canada, or England, I would encourage one of you, or I would have myself, figured out how to get that job and figured out how to make this happen. It's going to be harder in America, as many things turn out to be. So one of the things I learned about commercial insurance, which I did not know when I was a community psychiatrist only, was that employers get to set many benefits. So a fully insured team are America's small businesses. Dave's Auto Repair Shop, 50 employees. They write a check to a health plan. The health plan determines the benefits, And then the health plan takes all the risk for those 50 employees. Ford Motor Company, let's say 300,000 employees, made up numbers. They are self-insured. They feel that they can take the risk of their employees on. So in a 50-person company, Dave's Auto Shop, 2 people who need a bone marrow transplant, where they self-insured, would put Dave's Auto Body Shop out of business. They then become fully insured. When they're fully insured, a person in my job gets to pick their benefit structure. So I'll give some examples of that. Self-insured businesses, which are all the large businesses in America, including any of you who work for Stanford, Harvard, the Beth Israel Deaconess, right? These are all self-insured teams. That is to say, they decide whether they want to have telepsychotherapy. They decide whether they want to have a copay for methadone. They decide whether they want to have a $50 copay for Narcan. I was at a meeting not long ago, back in the before times when there were meetings, at Brandeis University. A nurse came up to me, quite sharp on the copay for Narcan. I'd done a lot of work to eliminate the copay for Narcan, and we gave away a lot of Narcan toolkits, extending the license of mine to the DEA to give toolkits to engaged employers like the carpenters, high-risk populations. And what she didn't realize is she was giving me a hard time. She worked for one of these very large teams. And I said, you know, if you guys wanted the copay to be 0, you could make it so. That is to say, the fully insureds like Dave Auto Shop are the ones that I get to convince the internal team why the copay or a benefit should be so. The self-insured teams, you can make a copay for Narcan $1,000 or you can make it free. She didn't realize that. And I think it was a good moment for her to see that. And that's what I want to share with you. Medicaid is a similar patchwork. Across America, Mass Health is among the best Medicaids. And not all Medicaids are the same in terms of what they cover. And many states, particularly the southern states, just per square inch, did not adopt Medicare expansion. So to say somebody has Medicaid is a little bit like saying they have commercial insurance. Commercial insurance may or may not cover a whole range of things depending on the plan they pick and the benefits that they have, and that includes Medicaid. But let's just say you were the largest, wealthiest company in the world. You could imagine what company that might be. You were probably playing with your phone. If they made a decision as a company to say, we have to pay for coordinated specialty care, every health plan would line up to figure it out. And they would be competing for their business with that involved in it. So I just want to emphasize to you, employers can drive this, HR leaders can drive it, health plans can drive it, but it's going to take some pieces from, this is just from my perspective. And so my survey question for you, have you ever spoken to your HR leader on what health plans you want? So I'm just going to take your answer. Before I took a job at a health plan, I thought health insurance was the thing that you picked in November to make sure that your kid's asthma coverage was attended to. That is what I thought. I now have come to understand that in America, and it looks like all of you have approached this the way I have. For that person who said yes, you are a sophisticated person and you were ahead of me before I worked for a health plan. So if you work for Dave's Auto Body and you're a small team, you have to pick an employment group that has a designated set of benefits that you might like. And if you work for an enormous team, like Stanford or Harvard or Apple, you could make the decision as an organization to have something become a benefit. So it wouldn't be you personally. Union rep during contract negotiations, that's another level of sophistication. It depends on whether, yeah, that's true. Unions are another intervening variable. Good point, duly noted. Thank you for that additional comment. But most people don't work in unions, you know, in America, which is a whole nother discussion. Okay, so I want to leave you with that point because I didn't understand this till I got a part-time job at a health plan. All right, next slide. All right. So here's what I've learned in my 9 years at a health plan. Leadership matters to improve services. If you don't have a CEO who wants to make things happen, you will have trouble making things happen. The self-insured versus fully insured benefit structure, I cannot emphasize this enough because the internal policy is advocacy within the health plan. So let's say that I got methadone to have zero cost share, zero copay and zero deductible. And that was a switch I flipped for the, let's say, 1 million plus or minus people who were fully insured. You had to go to each self-insured team. And again, these are big teams, Harvard. I'm just giving examples. Whether they're insured by any company is not Fidelity, the Boston Red Sox. Like you go to the big teams, right, in the Massachusetts area. And you say, do you want to have a zero copay methadone? And then an actuarial person will say it's 8 cents per member per month or 3 cents per member per month. Or actually, it's so little, we just want to give it to you. But then they have to decide whether to take it or not. And this is where you run into some attitudinal challenges. Not everybody believes that they have people with opiate addiction in their employment. So I have run up against this myself in personal conversations. So that's an interesting point. Self-insured is the ability of a person in my role to leverage internal resources to make a benefit change. Self-insured teams, this is Ford Motor Company as opposed to Dave's Auto Body, have to make their own decision about what benefits they would like. Mental health parity is an extremely powerful lever to effectuate this kind of change. And I think that you'll see over the past decade or so, there's been a series of attorney general actions, lawsuits, payments, as people try to interpret mental health parity. So I think this might be time for the next question. A little survey question. Has mental health parity been fully realized? Looks like unanimous opinion that it has not been fully realized. And so this is an interesting challenge. Going forward, you could do a whole nother webinar on the history of mental health access, challenge, lawsuits, attorney general action, that sort of thing. Let's take a look at the next slide. All right, here's some examples of what was accomplished at Blue Cross. And I want to emphasize that if you work in a health plan, this is an extreme team sport. Extreme. So you have to convince the people in the actuarial department, the medical leadership, the sales department, people dealing with the equivalent of Ford Motor Company, to make changes. And so there has to be a rationale that is clinical, administrative, and cost-based. So just an example, at my little health plan, it serves about 3 million members. So less than 1% of the American population, but it's dominant in Massachusetts. So we removed a for-profit carve-out in about 2010. We opened the provider network to anyone with an independent license. The first thing I did that my friends finally thought was cool was we no longer hassled anyone in an emergency room to send their patients to a hospital or to detox. And that was accomplished by the observation that on the medical side of the house, no orthopedic surgeons were called to evaluate just how fractured the femur was. That the orthopedic surgeon could decide if the patient was sick enough to be in the hospital, and they sent them. So it was directly through the analogy to the medical surgical side of the house that was accomplished. The copay and deductible for methadone, that's an important story because we didn't even have a network for methadone in the past. And that's going to become relevant later on because We set up 17 methadone clinics, and methadone utilization is up 800% since we did these things. But the methadone clinic has certain specifications, because when you're spending Ford Motor Company, Fidelity, the Red Sox money, you have to know what you're buying. This is a big takeaway from me. Okay, the 60-minute psychotherapy code. In 2015, we added that to the code system, and that was the first time in, I think, the 80-year history of the health plan that that was done. The Narcan toolkit was a kit of 2 doses of Narcan, an explanation for how to identify someone that had overdosed, and this was done with many of the construction sites and organizations in Massachusetts, and also with some towns that had been extremely hard hit. Overdose from opiates is a big crisis in Massachusetts. Before the pandemic, it was the epidemic of greatest interest. Methamphetamine, less dominant in Massachusetts. We see more opiate overdose. And of course, Narcan had a wide range of copays. And so we were able to eliminate the copay, again, for the fully insured. Dave's Auto Body wouldn't pay for Narcan. You just go to the pharmacy and get it for free. When I talked to the company that made Narcan, I learned that they had a term for when people walk away from a $50 or $100 copay, and it's called pharmaceutical abandonment, which sounds, more like attachment theory, but it's not attachment theory. People would learn that the Narcan was $100, $50, $25, and they say, I'm probably not going to use it. I'll see ya. And so when I talked to the people at Adapt Pharmaceuticals, I said, what's the story on this? And they said, well, if you eliminate the copay, everybody takes it. But if you make people pay money for it, some people don't have that money. And this gets back to the individual who confronted me at a nighttime addiction meeting about the high copay, which of course she and her team had arranged. So what I did then, the internal side, the Narcan toolkit and the elimination of the copay for the fully insured, we then went to every self-insured team and asked them would they actively consider removing their copay, given the 2,000 plus or minus people had overdosed and died in the Commonwealth of Massachusetts. A little bit later, we removed all the paperwork prior auth for outpatient psychotherapy. So this is a great example of the Serenity Prayer. It's this is something that was under my control if I could pull off enough relationships. So if you're doing outpatient psychotherapy at Blue Cross Blue Shield of Massachusetts, you don't have to ask us for anything. You just see your patients and send us a bill. And this has led to another 2,000 licensed practitioners joining Blue Cross, because we've tried to remove every imaginable hassle. Just recently, there was an article in the Boston Globe. We're going to pay teletherapy at 100% post the COVID emergency. And we're paying for phone sessions post the COVID emergency, which is new and unusual. And the argument behind that was there are people who don't have the internet or don't have privacy. And the idea is it's important for those people to have access to services, because what we learned was a lot of people won't be opening their offices even as we're halfway through an emergency and the emergency is stopped after there's a vaccine or whatever, that many people are still going to want to do this. We also incented collaborative care. Collaborative care, as you know, was developed at the Ames Center at the University of Washington and uses psychiatric resources very creatively. And we also increased the child psychiatry payment rates by 50%. And the idea is the scarcest resource in the mental health service network is a child psychiatrist. And many of them, of course, can just be paid privately. So that was a nice advocacy win. And that was just announced 2 weeks ago. And I've been contacted by several child psychiatrists who want to take insurance for the first time in their lives. It's hard to know, will that be enough to move people? Remember, they don't have to do any paperwork, any treatment plan reviews, any prior auths. And now we're paying them 50% more than we were paying them a month ago. So we're just going to have to see. But we've gotten pretty close to a hassle-free existence for them. All right, next slide, please. What might it take for private coverage for coordinated specialty care? Again, I'm not an expert. I'm just going to offer you my perspective. You can see my menu of things that we've accomplished in my run at Blue Cross. And what would I think it would take? Let's take the next slide. Please. So you have to have total clarity of purpose. So the elimination of prior auth in emergency rooms, total clarity of purpose. It took a year to convince people, the removal of all the paperwork for psychotherapy. You have to make a decision on what you want to accomplish and why. And you have to be able to, let the accounts know they're going to be paying for something that matters. You have to be using mental health parity as your lever in many cases. Employer demand is important. Do the employers want this? So I think this is a very interesting question. The employers are asking for more outpatient psychotherapy access. The young tech companies and the universities are seeing a lot of increase in demand for mental health services for psychotherapy. So by eliminating paperwork, allowing anybody to join the network, we had 2,000 extra people join the network. So the total network is about 15,000 people in Massachusetts who have independent licenses. That's an interesting challenge because coordinated specialty care is not going to be on the top of the list of the conversation points from an employer because it's relatively rare. So again, this is a weakness. So you might say, oh, this should be easy because it's relatively rare. It actually is a complication, in my opinion, because everybody understands the opiate crisis. I meet with the equivalent of Ford Motor Company. I say it's really important to eliminate the methadone copay. It's really important to eliminate the Narcan copay. 2,000 people died last year in Massachusetts. Some of them undoubtedly are connected with somebody who works for you. And they go, okay, I think you're right. How much will it cost? And some actuary says it costs 3 cents per member per month or 1 cent per member per month. It won't cost you anything because the number is so low. So the other piece is the individuals and families can demand things. So this is, again, the earlier point, people asking their leadership, their HR department, I want this thing. This thing's important to me. And ideally, your ideas are cost neutral or better. And actuaries are paid to figure that out. And they won't do the wave of the hand, back of the envelope analysis, which is how I've lived my entire life. They want to actually know the precise number that it will cost, because this has to be factored into selling a product. Because remember, back to the use of Ford, they're going to be competing, they're going to put out a bid and other people will be bidding for it. So everything I've done has increased cost. And obviously, if all the employer groups dropped our insurance as a result of my collective advocacy, I wouldn't have done a great deal of good. So this is the complication. So when you think about coordinated specialty care, there is some data, I believe, from the NIMH that you can make a pretty good case that this is cost neutral or better. And I think that's undoubtedly people on this call know more about that than I do. I do want to say a CPT code with exact specs of what is covered, staffing, etc., is essential. So I had a quirky thing in my elbow, and I had numbness in both my hands. And it turns out there was a thing in my elbow that was cutting off the nerve. Go to the hand surgeon. Hand surgeon says, oh, we have a thing for this. And what we're going to do is we'll do surgery on you. Then we're going to have 2 follow-up visits. Then we're going to send you to physical therapy for 3 visits. That's all one bundle. So it's a board-certified hand and elbow surgeon, a follow-up, physical therapy. That's a thing. You get a bill in the mail. And of course, the mathematics always are a little hard to understand. We charged you $12,000. Your health plan paid $3,000. You owe $100. But it was a thing. The surgery was a thing that's licensed and certified, right? You can't go to anybody. You have to go to a hand and elbow surgeon. So I experienced this bundled kind of care, some by intensely licensed people and some by less so, people in this surgical orbit. So there was a CPT code and there was precise exact specifications. I want to spend a minute on the idea of licensure or certification. if you're going to spend Ford Motor Company's money, and that's what health plans do, I want to emphasize this, we are spending other people's money. So you have to know what you're buying. And in a more sophisticated way, you have to be able to deliver results, outcomes, or metrics on why this is making a difference for their employees. So to say that I want to buy a car, right? Car should have 4 wheels, seats, should have a safety process around, airbags, that sort of thing. Like that's a car. So if I were to, look at motorcycles, it's not a car. Trucks, not a car, right? Like the idea is there's something I want that would carry 4 passengers, 4 wheels. There's a series of things that go with that. This, I think, and this is my observation, I don't pretend to understand everything about this. This, to me, is the most essential piece of this. So Blue Cross Blue Shield of Massachusetts did not have a methadone network for historical reasons. But because the Commonwealth of Massachusetts licensed methadone clinics, and they were certified to deliver methadone, once I convinced the internal groups within Blue Cross that we should have a methadone benefit, that we should have no one paying for it because we want people to get methadone because it saves lives, right? The contracting team, I had nothing to do with this. They worked hard. I did nothing. Set up the 17 opiate treatment providers in Massachusetts. A doctor who gives methadone out for pain that you can pick up at CVS is not a methadone clinic. And so the daily rate, what's advantageous about this is in a daily rate model, which is I think what coordinated specialty care will need, you're not just paying for the doctor's time or for the independently licensed psychologist or social worker's time. You're getting closer to a day rate. You're closer to assertive community treatment payment models. And so the idea is you get a daily payment. So to me, the CPT code is one piece of the puzzle. I understand from Michelle, there's been some discussion about that. But if I'm going to write checks of other people's money for coordinated specialty care, there has to be a very clear understanding of what it is and what it is not. It just has to be a very tight. And then when you lose your psychiatrist on that team or your lead psychologist, and you no longer have a peer worker or a person who does supported employment or education, you actually shouldn't be charging for it because it's no longer that thing. So this is a critical dimension of this. I appreciate its work. I don't know who would be the licensure or certification body. I think there are some potential candidates. I'm sure people on this call have thought about this. But this is what it would take. And if you could get that for me, I could figure out how to move the levers within my very progressive health plan to make something happen. Until I have that, I can't do it, right? Because I can't spend other people's money on something that's kind of a thing, right? It can't be a bicycle, can't be a motorcycle, can't be a truck, it has to be a car, right? And there's certain specifications that go with a car. So next slide. So let's take some questions, have a conversation. Again, this is just my perspective as a guy who's been advocating for mental health parity. And let's use a better email address for me. I missed that in the slides. My name is Ken, and I work for NAMI, my beloved organization. I am ken@nami.org. It's like a vanity license plate, to use a vehicular metaphor, ken@nami.org. So that's all. Happy to chat with you, take your questions, see what you think, because I know you've been in a series of conversations about this. And, I've had this run of practical success in working for a health plan, but I've never done this precise thing. So I'm very interested in your thoughts about it.
Thank you so much, Ken. Did you want to do your last poll question before we go to questions? You had one more poll question, I think.
Oh, yeah, the poll question. Let's do the poll question.
Okay.
Can we develop a licensure or certification for coordinated specialty care? That's the question.
Those folks are answering. It might be cool to kind of, if anyone's willing to kind of type into the chat their reasons why or why not. Kind of thinking, I think that'll be a really good way to start the discussion.
Okay, Michelle, any questions or thoughts that you might have or anybody in the audience wants to pursue?
So, Ken, I'd love to thank you so much. You've given us so much to think about, and it sounds like you've done it's really interesting history of some of the changes in Blue Cross Blue Shield. And being a clinician in Massachusetts, I think I've directly benefited from a lot of that advocacy, and knowing the history behind it is very helpful.
Good, yay.
As well. I wonder if you can tell us a little bit of like what you've heard of as the closest model for, you know, licensure certification of a thing that you think that coordinated specialty care for early psychosis could learn from. Is there a good model for this?
Well, I picked methadone because
Yeah.
before I got engaged in it, we didn't have any contracts with methadone clinics. And if you had the health plan card in your pocket, there wasn't a place for you to go. Methadone clinics are, of course, very intensely regulated by the federal government, have been around for more than 50 years. So they, of course, have had time to figure this out. But it was very interesting because they had a licensure and a certification, and I knew what I was, quote, buying with other people's money. We set up every opiate treatment provider in the state. Boom. Contracted, negotiated a rate. That's above my pay grade. I wasn't involved in that. I wasn't concerned about it because all I wanted was to have access to this benefit. And so a methadone clinic has staffing, right? It has an addiction specialist, medical director, who's board certified in addiction coverage or care. Then there's a series of staffers, licensed and unlicensed, peer recovery counselors who run certain groups. And then you're actually also paying for the methadone, which in the before times used to be administered daily. So you go to a methadone clinic every day, 365 days a year, and we were paying a day rate for that. That's why I think it's a good analogy, because you weren't paying a professional services rate for the addiction doctor. You weren't paying for the social worker to run a group. You weren't paying a social worker to supervise peers to do peer coaching. You pay a day rate. And the idea would be at the beginning of every month, you get a 30-day payment. And every day the person doesn't show, that's held back for the next month. So it encourages people to engage. Assertive community treatment is another example. But my experience with assertive community treatment has been more mixed. Because I'm from outside of Boston, I was very familiar with assertive community treatment. I grew up in the Midwest, and of course, assertive community treatment was developed in Madison, Wisconsin. And so when I was the state medical director, leaning into the commissioner role, we set up, I think, 16 assertive community treatment teams or PACT teams. And we had a day rate. So this was a DMH payment, which we worked with the Medicaid agreement to do that. What I observed for that model was under budget pressure, these programs get watered down. And so you have a psychiatrist and a nurse. You have certain specs for 60 to 100 patients, right? That was the original spec. If you look at, Stein and Test's original paper, that was the fidelity to the model. But of course, with budget cuts and increased demand, you have a team that's kind of a team. It's kind of not a team. They're taking care of 400 patients. Well, it's not a PAC team. That's a cool community intensive support program, but it's not assertive community treatment. So the problem that I observed with assertive community treatment is they couldn't maintain the model under the financial pressures. So I think there's only 2 or 3 PAC teams in Massachusetts now that still meet all the criteria. It might be 4 or 5, But, you know, it's been pretty humbling to set that up because staffing cuts and erosion of services during recessions, which are periodic assaults on public mental health budgets, a recurrent problem. And so keeping the fidelity to the PACT model and the payment would be the biggest challenge. So same thing with coordinated specialty care. You have to hold on to your staff. You can't get it watered down with other young adult stuff, right? You have to be really adhering to a model. But I do think if that were done, I think there are plenty of people who would love to advocate for this to be covered.
Mm. That sounds really important. Looks like Denise wrote in a question that says, wouldn't ACT rate setting reimbursement also be similar? Oh, I see. You already answered.
Yeah, I kind of answered that question. I think the answer is kind of, and methadone is kind of a similar example. Both day rates, which is why they're good examples, staffing requirements, fidelity to a model, independently being assessed. So the Department of Mental Health, that was my first job when I left the commissioner's role. I used to consult to the assertive community treatment teams to make sure they were following fidelity. So we had a little map and a little, you know, way to understand them. But I was impressed that under budget constraints that occurred in the collapse of the housing market 2008, 2009, at the end of that, you know, what's left on the beach is 4 or 5 programs instead of 15 or so. And the rest of the programs had gotten watered down.
So Catania wrote, I think connecting fidelity to the licensure is important and mitigates the watering down.
Correct. I think that's absolutely right. And I think this is the inherent tension with doing a program that isn't for an entire population of young people. You know, to really limit it to people with first episode of psychosis is a different model than for people who are vulnerable, turning 18 or turning 21, right? Which is a vulnerable population. I want to emphasize this.
Yes.
And I see this all the time, you know, in my roles. There's a lot of vulnerable people. But I think if you're trying to attend to this specific population and make this model happen, what's interesting you get on the other end is this model becomes sustainable. Like you don't have to beg for grants. You don't have to say to DMH, oh my goodness, please. You don't have to ask Anita Everett at SAMHSA, are you ever going to cut off the federal block grant for coordinated specialty care? The whole thing is self-winding because, you know, many people are on their parents' insurance, right? A lot of these occurred while people have private insurance. And this is one of the reasons I pursued that, even though I still consider myself a community psychiatrist, because people with community mental health problems now have private insurance. 3/4 of all psychiatric vulnerabilities occur before age 25. People are on their insurance till age 26. Okay, there it is. And this is how methadone happened. I think the conceptualization before the Affordable Care Act was that the private population didn't have a big addiction problem. Then, of course, you bring in everybody under 26, and then you have a whole different population that can sign up for health insurance. Boom. Right. So community mental health is now a piece of private health insurance. There's another question. I can't quite read all of it.
As if a bundled rate for coordinated specialty care ACT methadone is created for Medicaid, would a commercial insurer adopt this rate? If not, how would you negotiate a rate with Blue Cross Blue Shield?
We'll do that call in 2 years when there is such a thing. But essentially, all the health plans compete with each other, and they typically would do a different rate than Medicaid. So it is well established that private insurance pays better than Medicaid for many things. I can't promise how it would go in this regard, but the idea would be that the private insurers would set their own rate. Now, if the Division of Insurance or the insurance commissioner mandated that it be paid at a certain rate, lawsuits would ensue, years would be wasted, but that would only involve the fully insured market. Dave's Auto Body would be controlled by that. Ford can still do everything, anything they want.
Another question is, can you share the approximate average cost to an insurer of an inpatient psychiatric hospitalization for schizophrenia?
Yeah, I think, we could probably do that actuarial analysis, and I'm hoping that the people at NIMH and Coordinated Specialty Care know the answer to that. But so I'm going to give you broad strokes. Let's say a hospital day is $800 a day, made up number. And let's say the average length of stay is 3 weeks. 21 times 8 would be your number. What I found the first episode of psychosis, people are sick. The non-coordinated, non-specialty system doesn't do well with them. The psychiatrist in a private office can't manage them. They go back into the hospital. Right? And of course, as all of you know, it's easier to get into Harvard Medical School than it is to get into a state hospital bed. And so the idea that, people will find a long-term inpatient care system is improbable. And so the current way we're doing this is expensive for a small number of people, right? So this is the challenge we have is this is not a huge population, but they're getting poor care and it's expensive right now. And if we could together figure out how to do a coordinated specialty care certification licensure, right, they would find a rate. I can't tell you if it would be better or worse than Medicaid's. It's usually better, but they would find a rate to pay for it. And that is the exact kind of actuarial analysis somebody smarter than I would do, would figure out what does the first episode of schizophrenia cost in a year. Undoubtedly, there are economic people who've done that analysis. And people
I'm sure the rate would have to be better than kind of what typically gets reimbursed now. Like say on the Cedar Clinic, we get reimbursed for psychiatry time, we get reimbursed for therapy time, but we don't get reimbursed for all the coordination with the person.
Well, this is the whole point. The whole point is unlicensed people are not currently covered in most models. I was on the governor's peer recovery commission. It's quite possible that in the addiction space, people who pass a certification test, again, this word, and have a licensure and have been in recovery for X number of years and have taken an ethics exam and have taken a qualifying exam, it's quite possible that they will be unlicensed but certified and paid for by insurance. So I'm actively working that problem on the addiction side of the house, but what we're going to have are, the health plans are set up to pay for licensed private services, independently licensed people. So if you, Michelle, had a private practice, you're a psychologist, you're licensed, you could join the network, we'll write you checks. That's not helping with supported education. It's not helping with supported employment. It's not helping with the other pieces. So this is why this work matters. This is why this is a worthy task. Even if it's a 3-year goal, it's worthwhile to do it because, your clinic could be sustainable if insurance paid for a daily rate to cover things that aren't your professional time as a psychologist.
So Dr. Bao, who was our speaker last month, glad she's on, she wrote a question. What are your suggestions for coordinated specialty care provider organizations, especially those who started bundled payment discussion with public and private payers prior to COVID, to continue working on such payments in an economic downturn, such as the one we're going through?
That's a good question. So my health plan just announced 2 weeks ago the idea that they're going to cover phone calls through teletherapy, right? That's a lot of money in an economic downturn. So I would not give this up. Public services tend to do worse in recessions, and the health plans tend to have to focus on cost. So I would focus the attention on the cost of the uncoordinated specialty care person. And how does that compare to the person getting coordinated specialty care? Does that make sense? So the idea is the economic situation is going to go bad. The public beach is going to erode. I always think of mental health services when I'm on a Cape Cod beach. And, it's like, well, over the winter time, I thought there used to be a set of stairs there. And wasn't there dunes? No, there's nothing there now, right? And I think that I just feel like we have to capitalize on the time when there's money in the system. All the states are going to struggle now, right? But I would still stay with it, because if you can make an argument that it's same price, better care, people will go for that.
Yeah.
I've made that argument a dozen times, and that is, been a successful play. You don't have to always save money, but you have to say you'll get better care for the same money. And if you can reduce hospitalizations, which is a holy grail of health plan expenditure, I think that's really a good idea, because hospitalizations are expensive. Not really clear, how much people get out of them, but self-management, family psychoeducation, there are pieces in coordinated specialty care which will make a big difference in people's lives.
Yeah. So a couple of more comments that were written in. One could advocate that this is an economic downturn in which people are particularly aware of the importance of spending on public health.
That's true, but the budgets will be constrained.
Point.
So having been the commissioner of mental health, it's a great job when there's money. It is a nightmare when there isn't money, because states can't do what the feds can do, which is put it all on a credit card. States balance their budget. And so if the state revenues are low, they will cut programs. So this is why, leadership jobs in state mental health have a pretty short turnaround time. Once you go through a recession as a commissioner, you are a scarred person, because you didn't go into the job to close programs. And I was the commissioner during the 2003 recession, and I don't expect to go back to state government for that precise reason.
Sounds tough. It was hard.
I don't recommend it. Great education, but extremely painful.
Katanya wrote, I think we have to work on coordinated specialty care's license at the state level, such as ACT teams have. After coordinated specialty care's programs are recognized as a separate licensed entity, I think the path to bundled billing, the space, etc., specs, etc., will be made easier to travel.
I agree with that. I think it's exactly right. We're completely simpatico on this. This is what needs to happen. So there has to be a national set of standards. So Deborah Allness wrote the book on assertive community treatment. What is it? What does it do? Right? If you look at the Ames Center for Collaborative Care, they actually have job descriptions for the behavioral health case manager, the job description for the consulting psychiatrist. They have a spec for what it is, and that's why there's a CPT code that will pay for coordinated care, not coordinated specialty care for first episode psychosis, but rather for a population of people to be cared for in a primary care practice. So you need to have kind of a national set of expectations. And then once that is adhered to, then you can go ahead with state licensure. At least that's my opinion. Again, just having traveled in all these different places, that doesn't make me, an expert on any one of them, but these are just my observations. I think this can be done. I know many people are very bright on this call, and I've already thought about this. This is what I think is the linchpin. Without this, you don't have it. Once you have this, you then have a fighting chance. Repeat the name of the program. Primary care is the Ames Center. AIMS, University of Washington. This is Dr. Wayne Caton, who since passed away, who invented the idea that psychiatrists should not see patients on a retail basis. They should consult with the behavioral health case management to a population in a primary care group, and follow them on the PHQ-9, the GAD-7, and make sure that nobody falls through the cracks. That's the model of the AIMS Center. That's the integrated is the I. I can't remember the acronym for AIMS, but that's it. You'll find it very quickly if you Google AIMS, University of Washington.
Thank you. Anyone else have questions? I've been asking all of them.
A person will, wow, did I scare you with something I said?
You were simpatico together. I think that was a good thing.
Oh yeah, I think you're absolutely onto it. And so, what are the lead? It's my challenge to you is there are people like me inside of health plans, right? And I'm both inside and outside of a health plan, which makes for an unusual career. And I don't really recommend that. right? Because you have to be careful about your conflict of interest and related things. But this is just me as Ken, having worked at a health plan and having worked at NAMI. NAMI was very involved in the creation of the SAMHSA block grant. We were in Congress testifying. We had people who had experienced that kind of care, who had great outcomes. You know, I would say this is one of NAMI's bigger wins. NAMI didn't do it alone, but NAMI felt ownership over it, as with mental health parity. Other people contributed to mental health parity, but I think that NAMI has a big ownership role in coordinated specialty care. So I think that, you know, this is a challenge to you. And I don't know if there's a coordinating body or a group that's working on certification and licensure. If you can get that, you can breathe life into these programs for a very long time. And then you don't have to worry about grant cycles. You don't have to worry about the state block grant. You don't have to worry about arbitrary and capricious Department of Mental Health cuts. It's done. And once it's there, all the health plans will pay for it.
I think the time is really right for this, in that we're in a period in the United States where there are a lot of national organizing groups that are in greater communication and collaboration with each other than they ever have been, who are interested in early psychosis work. So it includes the SAMHSA MHTTCs, such as what is sponsoring this event, as well as PetNet, SMI Advisor, EpiNet. These are all different programs that are all working together right now, and many are involved in some real momentum around early psychosis. So I think this is really timely, in that those organizing bodies could be there and could have the momentum at this time, more so than they ever have before.
Yeah, and again, you know, I would defer to you on, you know, you, the collective you, on this conversation. You know, the American Psychiatric Association says, who's a psychiatrist? And once you pass their exam or do their training or beat your head against the wall, depending on how you think about our training, you are a psychiatrist. And then you can be paid as a psychiatrist. Like, you have done the thing which makes you billable through a third party.
Mm-hmm.
This happens with methadone clinics. This happens with assertive community treatment. This happens with the AIMS model for integrated behavioral health care, collaborative care, not coordinated specialty care. This can be done. I don't think it's easy. I don't think this is easy. But you then match a CPT code would pay a daily rate for a day of this service, right? So you'd have a peer leader, you'd have a supported employment, supported education resource, right? You'd have certain things that go along with this. And if you don't have it, you can't collect payment for it.
Looks like we have one last question from Justin. Could a certified licensed coordinated specialty care program operate within a general clinic, or would this need to be a distinct program with its own state regulatory operating certificate?
Yeah, that's a good question. That's probably more than I know. But to me, right, let's take the elbow surgery example, right? That guy's doing other surgeries. I went to his office and I got a bundled payment for a thing because of the problem that I had. So my answer to you, Justin, is it seems to me that this could be part of a clinic, but it would have to be together as an entity, like where it's housed, right? The Mass Mental Program was always in a different program than the main Massachusetts Mental Health Center, where I was the medical director for many years, because it was, the idea was young people wanted to hang out with young people. But I don't think it's essential that it be a different physical space, as long as the population being cared for was well circumscribed getting this thing, right?
Thank you so much. So it is 3 o'clock. We're going to have to say goodbye, but I just want to thank you again.
Thanks, everybody. And Michelle, you know, down the road, if I can be of help to you in this quest, I will give it my best effort. I think this is a big lift, but I think if you do this, your programs will be sustainable going forward. These methadone programs in Massachusetts have nothing to worry about, right? Private insurance covers them now, right? A lot of people, millions of Americans have private health insurance. Take good care, everybody. Thank you for having me.
Thank you.
All right, bye now. Have a great day.
Fun.